But we're going to continue with our program with a really timely, really exciting conversation about long-term care. And we are so lucky to have such a dynamic and wonderful lineup for you, some of the leading experts on this issue nationally and also in the States. And to introduce our panel, I'm going to turn it over to my dear friend and a new member of the Academy, Helaine Olen, from the American Economic Liberties Project. And many of you may be familiar with her longtime column at the Washington Post. So Helaine, take it away.
Hey there. Can everybody hear me? Okay. I'm Helaine Olen, and these days, as Rebecca said, I'm at the American Economic Liberties Project. I also occasionally write for MSNBC, where I actually did a column on long-term care, I think, last year. But anyway, I want to open this up with a question for the audience, which is, how many of you have had to deal with long-term care of either a parent, relative, child? How many of you are doing it now? I'm going to out myself here. I am also the daughter of an 80-year-old mom with dementia. And I actually almost didn't make it here this week because my mom was in the hospital this past weekend. But she's fine. It was just that my dad couldn't deal for a day. So I obviously have a very both personal and professional interest in this topic. As we all know, I think in this room, I don't have to repeat some of the basic facts, but I will anyway. There are approximately, 60 million Americans age 65 and older. By they are about 1 in 5 Americans by 2030. People don't only live longer, they live more ill, meaning they're more likely to need long-term care. And of course, they're not the only Americans needing long-term care. There are people who are, disabled as well. And they also need help. And they are in a country where, especially compared to some of our peer countries, we don't get much in the way of help at all. This is a crisis. Men and women who step out of the workforce to take this on will lose hundreds of thousands of dollars in earnings. Of course, women lose more than men, but men also lose a significant sum. This panel is a look at the issue of long-term care. Where are we? What does the future look like? At these conferences, it's traditional for people to open up with a short statement, and we're going to skip that because I think I just want to get to questions, and I suspect so does everyone else. So I'm just going to do some very quick introductions, and then I'm just going to plunge in, starting with Nicole Jorwic, who is the Chief of Campaigns and Advocacy at Caring Across Generations. Alison Barkoff, who is I think if I've got this right, the Harold and Jane Hirsch Associate Professor of Health, Law, and Policy at the Milken Institute School of Public Health at George Washington University. Did I get this right? And she also was recently in the Biden administration, leading the administration for community living in the U.S. Department of Health and Human Services. Ben Veghte, right? Veghte. Is the Director of Long-Term Services and Support Trust at the Washington State Department of Social and Health Services, where he leads the initiative to implement and administer Washington State's new program. And finally, Connie Garner, who probably doesn't need an introduction to anyone here. I don't think anyone really needed an introduction here, but Connie especially, who is on the Academy's Board of Directors and is now CEO of Garner Policy Strategies. I'm going to read this. She leverages legislative, healthcare, and government agency and nonprofit and private sector consulting experience to help clients develop strategies on disability issues. So I'm just going to start with a very basic question. And I want to say everybody should join in and talk. You can talk over each other. I will take questions from the audience towards the end. And I just want to say, no, I am not checking my messages. I don't have a clock near me, so I have to keep track of the time. So if I look down, that's what's going on. So I'm going to start with you, Nicole. Is long-term care a crisis, and why is it a crisis if it is?
Yes, the long-term care system is in crisis, and frankly, it's been such a rolling crisis. Just like we talk about the workforce crisis, it's beyond a crisis point. We're at a catastrophic moment. The long-term care system has continually relied on mostly Medicaid, a program that has very strict financial and eligibility requirements and has never been appropriately funded by the federal government or states, leaving many millions of people without services that they need and relying on unpaid family caregivers to fill in the gaps for services. This is for a variety of reasons, but the fact everybody ages, and also everybody could be in need of long-term care at any given moment. I have a brother, Chris, who has autism, who receives Medicaid home and community-based services, and his program is far from perfect, but he's one of the lucky ones in my home state of Illinois, where there's 20,000 people on a waiting list. The waiting list nationally, according to Strat News, if people lined up, would go from Chicago to Cleveland. And for people not from the Midwest like me, that's a really long way. It's about 500 miles. And that is just unsustainable and unacceptable in a country where 1 million people a day are turning 65. We're at a crisis point and really need solutions.
Connie, what do you see in this area?
Well, I agree with Nicole unquestionably that we're in a crisis. And I think it's because of two things. One is because we have not been willing to accept in this country that you don't know who you're going to be 24 hours from now. We're not able to understand that or accept it. And so until it happens, until you live with it, that's the first time you're going to deal with it. And we saw that throughout the whole, as you know, I worked for a very long time on the Class Act, which has a long history and a lot of learned lessons as a result of that work that we did for Ted Kennedy and his family. And so one of the biggest pieces, one of the biggest problems is that people just don't understand, or they don't want to accept the fact that you cannot predict, not one person in this room knows who they're going to be at 5 o'clock tomorrow. You don't. And so we don't have the commitment to a safety net other than Medicaid, which can't really accept a whole lot more pressure without going broke, to be able to fix this the correct way. So I think that's one reason that we have it. Second, as Nicole has talked about, there's a workforce crisis because, you know, we don't even have a way to encourage people to do this as part of their career. I'm a nurse practitioner by trade, and I can tell you the way the different categories within the nursing field, and I want to put this as, you know, one of those in some respects, is viewed based on who they are. And we don't do anything to make this an attractive profession. So we don't have a pipeline. We do have a pipeline problem, but we don't have a pipeline that really can work for us. So I think that's an issue. The other is an issue of not knowing where we're going to be. And then we did have a lot of success, unfortunately, with real people when we did the Class Act. They wanted it. They wanted to risk it. They wanted to see whether they could make it work or not, and they were not given that opportunity. It was just taken away from them. And so interestingly, we've had a coalition of folks that for the last, 12 years, it's been about 12 years since then, have worked together on trying to come up with solutions. It's a mix between aging and disability. Several times when we have tried to say, the fat lady sang, it's time to throw in the towel. No, we're not doing it. So they're still working. They're still there. They still care, and they're still working. And so I think those are some of the reasons. I mean, when it's very hard to turn around to real people and say, it doesn't matter what you say. We are actuaries, and we will tell you that it'll be too expensive, and it may have been, but they weren't given the opportunity to be able to even try. And I can tell you, when I would go out and talk to different groups, the one that was the most significant about this was the PTA. Now, people would say, why are you talking to the PTA for long-term care? Because what we were trying to point out was you have kids that once they get into their late teens and their early 20s, okay, and you have no backup for long-term services and supports to meet functional limitation needs at all. But those kids go to beach week. If you have kids, you know what the beach week thing is all about. They go to beach week, somebody jumps off the deck, somebody goes into the water, you're looking at a broken net, and that is your retirement. Okay, you got nothing for the kids or yourself. That is your retirement. You could hear a pin drop when we would talk about that. And so there was interest that we've never really followed. You know, I always wish that we would have more hearings on it, because one of the groups I want to tell their story and put a face on the issue are the guys who drive the squads that come and pick you up for 911. They can tell you the story of what happens when you don't have the right kind of long-term services and supports available across the lifespan. It's not just about age, it's really across the lifespan when you have a functional limitation. So I think, to answer the question a long way, that is what I would argue are some of the reasons why we're seeing what we're seeing now. Go ahead.
Can I just add in, we've kind of talked about the fact that we don't have access to services and supports. We've talked about the workforce crisis. I would push back on the fact that we actually do not have a system when people talk about a system of long-term services and supports. We don't. We have a hodgepodge. People think that Medicare, I'm all set. I have Medicare. Of course, Medicare doesn't cover long-term services and supports. People don't understand the incredible strict eligibility to get long-term services and supports in Medicaid. And what we truly have right now as the backbone of the long-term services and supports quote-unquote system is unpaid family caregivers. We have 53 million people in this country who are providing daily care, a study that has up to 100 million people who are providing some kind of support to a person with a disability or older adult, and at huge financial consequences, $600 billion in people leaving jobs, leaving the economy. And COVID really, I think, highlighted and created this visibility where we would be seeing every day people losing services and supports and family members having to leave. And I do think the one glass slightly half full moment is we have this visibility right now, bringing together, as Nicole I'm sure will talk about, people who need services and supports, aging and disability, workforce, and family caregivers in a really momentous kind of way.
Why is this, as I put it in my questions to you, all of you, why is this always the bridesmaid, never the bride of issues?
I think part of it is the fact that people don't understand the systems that they don't have, and also people don't want to think, to Connie's point, that it could be something that they need at any moment. We did polling at Caring Across Generations that showed that 93% of Americans believe that Medicare should cover long-term care, and 66% of people are very confident in their belief that it does. It doesn't. Mm-hmm. And that reality and that complication, I think, is the complication and complexity of the programs, I think, is also why it's hard. Medicaid, in California, it's Medi-Cal. In Wisconsin, it's Badger Care. In Tennessee, it's TennCare. And that means that people who are receiving the services don't understand what's at risk and don't understand what needs more investment. And so part of why, and it's expensive, like the underlying piece is that it's expensive. There's been decades of work on quote unquote rebalancing the system, but the system is not balanced to what people actually want. 95% of disabled people and 90% of older adults want to be in their homes and communities. There is not 95% or 90% of even that hodgepodge system that is going into those systems. So it's expensive, it's complicated, that's why.
What percentage is going to home care versus institutional care?
Well, we are now a little bit more than 60% when you look across all of this is just Medicaid LTSS funding. That was a big deal. But if you look at subpopulations, they're very different. If you look, for example, people with intellectual and developmental disabilities, way in the high 80s. If we look at kind of older adults, below the 50% mark. So we really have to drill down. We have done a good job rebalancing, but because the way Medicaid is so focused by waivers on different populations, we have done better and worse in other populations. I'll say people with mental health disabilities, the worst of the worst. So I think we really need to start looking at how do we do this across the board, because as Nicole said, this is across the board. People wanting to age in place, people wanting to stay in their own homes and communities.
On that note, I'm going to turn to Ben. You are running Washington State's newish program. Can you tell people about it for a minute, and how are people responding to it? How is it going, basically?
Sure. Thank you so much. It's going really well. We were enacted in 2019. We started collecting premiums in 2023. We start paying benefits next summer. It's a universal mandatory program where everyone contributes about 0.5% of their wages. The premium rate is 0.58%, and then you get a benefit of $36,500 worth of long-term care whenever you need it later in life. And then, of course, it's updated for inflation over time, the benefit amount. We're also working now to create a supplemental statutory framework for supplemental private insurance, so that private carriers could take our program as the deductible, our benefit as deductible, and price and market coverage on top of it, which would allow middle-class people to buy an extra $50,000 to $250,000 of additional coverage on top of the public benefit, kind of analogous to what Social Security and 401k IRA is in the retirement security space. We're trying to do that in the long-term care space. And it's it's gaining popularity every year. We've done a lot of outreach with community-based groups to help them understand that the family caregiving issues that they're dealing with are not just their own private problem, but it's a problem we all face. And even our polling shows that even conservative subgroups of our population that are very anti-government, they long for community solutions. They long for community, and we don't talk about our program as a government program. We talk about it as a solving family problem, together, and that resonates well. And last summer there was an attempt to repeal or last fall rather, to repeal our program through a ballot initiative that would have made our program voluntary, and we defeated it. So a majority of Washingtonians actually voted to keep a mandatory payroll tax that could have become a voluntary payroll tax. So I think it's going very well, and I think a lot of other states are starting to look at us as a model.
What was the argument that helped defeat this potential rollback? What resonated with voters, did you feel?
The family caregivers, that is really the in to people, is talking about family caregiving because almost everyone has dealt with that. And people don't, as we were talking about in the previous question, Americans as a whole, we don't tend to think of ourselves being frail or having cognitive problems when they're older. That's not the case in Europe and Asia. It's much more easy. People understand that issue much more intuitively in those countries, for some reason, in those cultures. But for Americans, it's hard for us to understand. But people do understand family caregiving, so we talk about family caregiving a lot. And we also talk about the we group. I think that in this era, there is a need for social cohesion. And I think social insurance is a moment of social cohesion, something to where we all pitch in and we all benefit. Originally, social insurance was not originally government programs. It was originally the guilds in the 1300s and 1400s in professions in Europe doing self-help initiatives, worker self-help funds, right? It wasn't government until late 19th century when Bismarck took it over and nationalized it. But really at its heart, social insurance is just a community-based solution where families face risks and we try to pitch in to help each other. And that's how we talk about walk cares with people, and that resonates with people.
Is there a country you feel really gets this right?
Sure. There are about a dozen countries that have universal coverage, and I think that's the foundation of a solution for several reasons. One is that upper middle class people and wealthy people have a stake in the quality of care that the system provides. I don't need to explain that to a social insurance audience. And so that's a huge advantage. There's an ancillary advantage as well, additionally, which is that when there's a universal program with benefits that are at least modest, if not robust, a lot of money flows into the long-term care infrastructure, which encourages business formation in the provider space. And there's a shortage of providers, so we need people to be forming long-term care, home care agencies, for example. And that there's a guaranteed return on investment if there's a lot of money in the system. A second thing is that, looking at the Netherlands as an example, we can learn from them that they realized they have a comprehensive universal system that they realized was going to be fiscally unsustainable in 20 years. And so they knew, given the fiscal and workforce constraints, they had to redesign their system to be focused less on institutional care and more on person-centered aging. And so they're going away from nursing home care. But it's not just a question of saying we want to fund home care instead of nursing home care. They're trying to get away from formal care altogether through multi-sector, there you are, Alison,
yeah.
Multi-sector planning to bring together social housing associations, nursing care providers, governments, to try to create retirement communities where people can move to before they're sick and frail, where they can have what they call reciprocal care, where they care for each other, and other things like that. So those are some of the key things I think we can learn.
I have another question for you, but Alison, how is that different from, like, say, in the United States, where somebody would buy in with their own money into a continuing care community?
Yeah, I mean, when I hear this, I think, wow, this sounds so amazing. And I am now, as you mentioned, just joined GW, and I'm teaching students, and I'm having to kind of burst their bubble on day one when they're like, healthcare is a human right. And I'm like, not in this country. People think like, oh, I am going to get the same tattoo as Rebecca that says eligibility doesn't equal access. And so, I mean, I think the things you are talking about are the things that if you are very wealthy in this country and you have a lot of money, you could buy into a assisted living. I mean, when we look at what are even the abilities of people to privately pay, we just don't have anything that is affordable at all in this country. And it's because, the systems really push you into either having to spend down into a poverty program as the only thing or relying on families. So we don't have that. And just, the mention that Ben said, what we are starting to see, the federal government in the last administration was trying to put some wind behind it, but we are seeing in states the reference to multi-sector plans on aging and people saying, actually, like aging in place is not just about long-term care, it's about accessible communities, it's about affordable housing, it's about transportation. How do we bring all of those sectors together? So I think there is some very nascent kind of something we could build on, but we are very, very far in our system from something like
Nicole wants to say something, right?
Well, just to name that any multi-sector plan should not just be for aging, it should be aging and disability and caregivers. Have to say it everywhere I go.
And read my article coming up soon in Generations about really the shared common interest. I know you have a question on that, but people are aging into disability, people are aging with disabilities, and the intersection of the aging and disability community on all of this. And we have great examples of states like California bringing everyone to the table that really has a shared interest.
And one more point to emphasize what Alison was speaking to is the affordability of what the Dutch are doing. For example, there's two components to it. There's the care component, and the universal long-term care system covers that part of it. And then there's the housing component. And housing is even more important than access to long-term care in many ways, because without affordable housing, that you can't age in place. And so what most European countries have done, and the Dutch are an example, is invest heavily in affordable housing, they call social housing, for everyone, but also for seniors. A third of Dutch seniors live in social housing, and their rent, on average, is about $620 a month. Okay, and that's in what we call independent living communities. So in Seattle, or in Washington State, the average for an independent living community is about $5,000 a month. So that shows you the affordability. To address affordability of aging in place, you need to have housing policies that support affordable housing.
Okay, and how do people in the Netherlands volunteer to move into these places? How does this work exactly?
They love it. They're very social.
Okay.
They're very so they move in their mid-60s before they have significant health problems, and they do love it. They're often located near city centers where they can walk or have a bus ride to the markets to get their fruits and vegetables and things like that. And it's very popular.
Go ahead, Nicole.
I just wanted to name, I completely concur that housing is just as much of a piece, and it's also a way that our Medicaid system needs to be modernized, because people on the Hill will look at you and say that Medicaid doesn't cover room and board, but that's not true, because Medicaid covers nursing homes. And so when we're looking at modernizing long-term care generally, we also need to look at the realities. There are programs that show, like Money Follows a Person, that shows people who choose to live in the home and community when some flexibilities like paying for rent or maybe even an assisted living and that kind of thing saves Medicaid 20% per beneficiary per month. So that's just something that the housing and care components cannot be disconnected.
Okay. I wanted to go back to Connie for a second. One of the things that's coming up here is how expensive long-term care is. At the same time, of course, there's a worker issue here. They're very underpaid. There's a shortage of workers. Where is the disconnect here, and how can we address this?
There is a disconnect. There's no question about that. I don't know if this is on.
It is now.
I can hear it. Okay. I'm not sure, actually, how I would even answer that question.
Okay.
I'm really not sure. Let's say, Nicole, take that.
Nicole, okay.
For sure.
In wearing another hat as a advisor for the National Alliance for Direct Support Professionals, which is the workforce that specifically serves people with IDD, the biggest disconnect and issue with the workforce is the fact that their wages are paid by Medicaid, and they do not pay well. To Connie's point, there is not who is going into a high school classroom saying direct care is really the way that you should go with your career when the average wages are $16 an hour. So the issue, the disconnect is actually the fact that both are funded by a program that are not funded appropriately by either the state and the federal government. And so when you have a career, a job that is not a career, you have people who could make more working at Costco or going somewhere else that with much less physically demanding labor. And then you have a workforce that on average 50% are on some other form of public assistance. So that disconnect is because the public assistant program, the Medicaid is paying the low wages, but we're still paying on the other side.
And I'll just add that this is the #1 quickest growing occupation. We need 1 million more from where we are, direct care workers, direct support professionals to support. We heard the huge number of older adults who are turning 65, 11 million people every day turning 65. Huge, sorry, must be. Anyways, huge numbers of people, older and people with disabilities living longer, yet we are seeing huge number of people leaving this workforce. Something that just came out from ANCWR every year does kind of the state of the workforce. 90% of providers, despite the demand, are having workforce shortages. 50% or more turnover in this workforce. And it's because, as Nicole said, you can make more money working at Target, working at McDonald's. The opportunities for advancement are not there. Lack of benefits. And so we really have a huge problem. I think you're going to ask in a minute about immigration. So put that overlay on. It's really, really challenging.
Yeah.
If I could add one quick thing, and that's one of the big advantages, and I love because we're at the National Academy of Social Insurance, I love talking about social insurance. A big advantage of a social insurance approach here is that you have a 75-year actuarial horizon, okay? As you all know, on the state level, Medicaid programs, there's a zero-sum game between worker wages and the amount of benefits you can pay out. I work in a state agency right now, so I see it every year. We have to kind of figure out, okay, if wages go up, that means benefits go, fewer people can be served. It's a horrible zero-sum game. With social insurance, you have a 75-year actual horizon, which means you have reserves you build up, and the math it's not an annual appropriations battle over that zero-sum game, and you can make long-term strategic investments, have a good collective bargaining agreement with strong weight, and we do in Washington State, but then also make investments in other aspects of the long-term care infrastructure that make it work better because everyone's in the same boat, and it's a societal investment towards the future. So social insurance makes it easier to pay workers better, I think.
What percentage of the long-term care workforce are immigrants? Do we have a sense?
I'd have to look in my signal, but a very high percentage. And the majority, what I can say in front of a bunch of academics with integrity is to say that the majority of the direct care workforce are women of color, and immigrants. And that's an incredibly important component. That's why I was at the ARC of the United States. Hi to Marty Ford, who I've learned everything I know about long-term care from, along with Connie and others. But the reality is that on the immigration side, you have provider agencies who will come out as job creators in states like Alabama, who will talk about why we need a guest worker program. It's a unifying issue when you can get outside of the political morass.
And I'll just mention, I was really surprised but pleased to see, maybe it was about a year ago, the Bipartisan Policy Center put out a report on workforce. And again, this was a bipartisan report. They had people from all over, and there was an entire chapter, to Nicole's point, on we really need to have a visa program, the way that other types of visa programs exist, to bring in workers to fill this huge need. It is something that people are not taking jobs from Americans. We can't fill these roles. And again, it was kind of put out there as a bipartisan idea and solution, and probably one that will need to be really seriously considered if we're going to think about addressing the workforce crisis.
Has there been any legislation on the Hill, like in this direction?
There have been pieces of legislation introduced on things like a visa program, and there also has been legislation introduced generally on raising direct care wages. To Ben's point, the issues of services, access to services, and workforce are directly tied. So that there was the Better Care, Better Jobs Act that connected those two pieces together, and that's really what we need to see, because yes, we want to be able to create that pipeline that Connie talked about, but we also want to make these good jobs. We don't want to bring people in or have people who are currently in the workforce making such low wages.
I think based on what you're saying also, we need to professionalize what this role is all about, because it's not professional. The way it's dealt with, the way it's treated, the way it's paid, the way it's given benefits or not given benefits. And I think until we make a concerted effort, which is why I've always said, why are we not sitting with the higher ed people? Why do we always stay in our own little box? Well, I mean, we need to have a conversation with the higher ed folks about what goes on with this, because there are, programs that are in universities that help people get prepared to be able to do this. Why are they not taking the OTPT speech and language guys they have in, for example, George Mason, across the street to where they have a whole center where they could be working? No, don't do it. Don't do it. They do the traditional, let's all go to the hospital and do that 2 days, during a semester or something. So, I think the whole issue of professionalism for this is important, and we need to have the message further than the small group that we usually tend to have these conversations with, I think.
Yeah, I'll just mention that when I was at HHS, we entered into a partnership with the Department of Labor and agencies across HHS, including ACL and CMS, and kind of launching a direct care workforce strategy center and starting to think about, okay, how can we think about apprenticeship? How can we think about community college? The one thing that I will just flag in terms of legislation, the biggest investment ever, at least in the last since the ACA, was the ARPA, the American Rescue Plan Act, which ended up having $37 billion going into Medicaid HCBS. Every single state took it. And if you look, and you can go to CMS's website about what every single state used the money for, literally every single state used it for workforce, but it was one-time money, and they were very nervous about, okay, if we raise wages, what's going to happen? We are hitting the end of the time period in 2 months for states to be able to use that ARPA funding. We're about to hit a cliff. I will say part of what the strategy center was, okay, how do we get into workforce funding, and how do we really get into some of those pieces? But I'm actually concerned that this crisis is going to get much worse. We'll probably talk in a minute about what could be ahead, obviously with cuts to Medicaid and the pressure that would put on. But even if things stayed status quo, the end of the ARPA funding is this cliff that many states are about to.
And we're already seeing it in our Medicaid program. The cliff is there, and that's, again, the virtue of social insurance. There's no cliff there. You could sustain better quality jobs over the long term. You don't have a cliff where suddenly you have to choose between dropping the wages or reducing access to Medicaid.
This is going to sound like an out there question a little bit, but one thing that occurred to me while sitting here is Medicare Advantage putting more pressure on long-term care, because you're beginning to hear about people being tossed out of, ProPublica has done a bit of reporting on this, of people being, told to leave rehab centers before medically they medically should, at least according to their family members. Somebody want to talk about this? Or you can. Okay.
I'll do the controversial part. No.
Okay.
Medicare Advantage certainly puts a lot of pressure on the broader long-term care system, because Medicare Advantage plans have made a lot of people believe that they will have coverage for long-term care that they will not.
How do they do that?
By putting on commercials on CNN that say that they will cover long-term care. And when you look at things like the pieces in ProPublica and other things, if there is a benefit, the benefit's so narrow that it's not going to really help, or they'll do everything in their power to kick people out. And so when Medicare Advantage, because it's being run by corporations who have a obvious skin in the game in terms of trying to make money off of these programs, the way to do that is to not provide services, and long-term care are some of the most expensive services that Medicare Advantage plans are claiming that they're covering.
Yeah, I think just the other thing I'll add to that, in addition to kind of the lack of transparency / misrepresentation, is really to Connie's point, like people need to look at what the benefit is. If it is, we will have someone come 3 hours a week to come help you with something, that is really, really, I'll use the word skinny benefit, maybe is a way to describe that. Maybe that will help someone who is like just starting to have some limited ADL kinds of needs. If we're talking about someone who really needs long-term services and supports and a Medicaid, that's a pretty high standard. You have to essentially in most programs meet a quote institutional level of care. You may think, oh, I'm all set because they said long-term care and home health care and home care, and it's not the level of support that you need. And I think really being brass tacks, you can probably in your own experience in dealing with your mother and her needs, you have to look at what level of support, and it's really minuscule.
Connie, you looked like you wanted to say something.
No, I'm just thinking about what she said, and you're absolutely right. And, Nicole knows this. This is just a real hard time for me right now because 15 minutes ago, I got a call from the genetics folks up at Hopkins to inform me that my daughter, who has a developmental disability, but as we talked about, not knowing what's going to happen tomorrow, woke up one Saturday and couldn't walk. And so we've had her evaluated for the last 3 months at Hopkins from neurology, genetics. So 10 minutes ago, 10 minutes before we started, the genetics folks called and they said, we just want you to know that we found out what was wrong. And she has a very, very, very rare disorder where her brain has too much iron in it. And now she's having these symptoms that are kind of almost look like, you have a neurodegenerative, problem. Now, I'm like, oh, okay, so is there something to do for it? Well, yeah, there's some medications that are going to treat the symptoms. Okay, I don't know enough until I go home about what the rest of this is all about. But for 10 seconds, I stood there thinking, oh my God, what's going to happen? She has a job. She is disabled. She has a job. Can she still work? Where's Medicaid going to be? Because the Medicaid people I have to deal with have no clue about the people who actually are in and insured in their system. They don't, the case manager, they don't even know what the case is all about. They don't bother to read it. So I have argued to the insurance companies who have accepted this responsibility in terms of what the quality of people are they have even looking at Medicaid as a whole. So I'm sitting there for that 10-second period thinking, what's going to happen? What's going to be in the future? We're talking about a service system that doesn't even work. It's not even in place the way we want it to be. So that means I'm in charge of the care. And so everything that you're talking about in terms of the care is real and it's going to be fun. But I say this to you, the only reason I tell you this story is because it happened so recently. But also, this notion of not understanding how anybody, not just me, can be in that situation tomorrow is important because it needs to be what drives the investment that the citizens in this country have to make this work and to deal with it, because you are not abstained from this. And I was the last person who thought I would get a call from Johns Hopkins saying she's got a very rare genetic disorder that isn't even associated with you or your husband. She just happened to have developed it. So, I mean, that's the kind of stuff that people don't think about when I say they don't think about it, because if they did, then we would look like Australia. I mean, I know whether you've spent some time. I spent some time when we were doing class looking at the system in Australia. They, in fact, started it using the disability folks as their target. And then we're planning to move to aging. But I mean, these are people who have appreciated, and that's the piece that we're not, and you would think after all that's happened here from 9/11 on, that this country would understand that, but they don't. So that's what I was thinking about when you saw me looking kind of.
Yes, I was, we're all there for each other. And I think what Connie's point brings up is something that has also come up for me. Like, we're quote unquote national experts on these issues, and we can't always figure out, or I can say as somebody who is on the care team for my grandma with Parkinson's and my brother, it's an impossible thing to figure out. And then you layer in, and we're quote unquote experts. And so when you think about things like Medicare Advantage, when you think about folks that are dealing with the need of long-term care, oftentimes that isn't a crisis moment. And because the systems are so complicated and people wrongly assume that they're going to be covered by different things, those things are appealing, like a Medicare Advantage plan, and folks don't realize what they're losing when they make those decisions. And so that's fundamentally the problem that we're all dealing with, including those of us on the panel.
I'm going to use this as an excuse to transition, and we'll open this up to questions in around 5 minutes or so. But I wanted to bring this back to Washington for a minute. I mean, we're in a climate where, if anything, we might see Medicare Advantage expanded. But what do we see coming out of Washington on this issue, both, positive or negative in the next couple of years? I mean, I have to say this week is not looking very promising, and I'll leave it at that. But
Well, the one promising thing of everything that happened yesterday with the freeze and in particular the Medicaid portals being down is that it's the first time in my 10 or 12 years that I've seen Medicaid trending, and I think that that's what we have to be leaning into that because we have to make sure that people are paying attention to these issues because what we're expecting in the next couple of years is a lot of threats. In 2017, Alison and I worked very closely with a lot of folks in this room in defense of the Affordable Care Act, and because the threats to it were being funded by almost $1 trillion of cuts to the Medicaid program. Some of those same per capita caps, work requirements, all of those things that ultimately are cuts to the program are currently being contemplated, including to pay for massive tax cuts for the wealthy and corporations. And so that's what we have to be doing is elevating these issues, elevating this need. We know that in exit pollings that our friends at National Women's Law Center did, that access to aging and disability care was the #1 of our care issues that were on people's minds. And so we need to be reminding people of that because there is hope. We are a nonpartisan organization. I have, especially during my time at the ARC, and always really focused on building bipartisan relationships. And so we have to make them scared of coming for Medicaid and also make them see the need to do things in Medicare. Right. It was only 2 months ago or 3 months ago that we were publishing papers about Medicare at home. We can circle back to that, but first we have to protect what we have.
Yeah, I mean, I'll just add that I think the one thing we heard from the last panel, and again, there's been like bipartisan polling coming out, it's really important kind of the narratives we give, and it's not just talking about like aging and disability services, but caregiving, the way we just heard from Ben. Like the poll that came out before the election was that, well over 80% of people said this was a major issue, and almost 35% said it was like their top issue. It was very supported in investments across both Republicans and Democrats. And I find, in the role that I was in ACL, like we had a lot of support because it is really most people have that experience of being a caregiver, having received care. It is so universal. And so in some of the ways that we're talking about it, it's always about who's the messenger. And we need to be lifting up what the impact, not just cuts on Medicaid, but again, like our family caregiver supports, our respite programs. So many of those are really also at stake. And then finding maybe those pieces that we might be able to move forward. So I think it's a really, really powerful lens to bring together aging, disability, labor, and add in really the caregiving movement.
Is there anything anybody thinks could be brought forward? Yeah. Go.
Yeah,
I do think. So one of the things that the group I originally told you about that's still in place, what we're looking at is what policy questions are out there to be answered that we could look at that would actually strengthen alternatives so that it's not always this discussion about Medicaid and Medicare and like what is on the tax side of things that we could do differently. So there are a couple different issues and options that have come up as we've met. One is to take a look, and again, these are policy questions right now. Is there a way to look at the ABLE Act? And I'm not sure whether you know about the ABLE Act or not, but it's right now mostly for people with disabilities. I guess what's the age up to now? 60, maybe 60. It started out about 15 years ago, and it's an interesting program. It was for people with disabilities because you can't save for your kids. At that time, you couldn't save for your kids and have money for them because it would violate the Medicaid rules. So it was always worrying about making sure that Medicaid was available. And so what that bill did was set up a different program called an ABLE account, and that account is run by the banks, actually, who are invested in it. It has a eligibility definition it's really good. They actually pulled it from the Family Opportunity Act. So I'm just saying there are things to build on. It doesn't have to start from scratch. And so the question is there something we could do with that? The Republicans are heavily invested in it. They were from the very beginning. So that piece is already there that we could build on as well. So we're looking at that. Over the years, whenever the tax bill comes up, two things happen with this piece of legislation. One is they make the age longer. It started out as a bill really for Down syndrome, and that those were the groups that actually pushed it. And so if you had whatever your disability was, for their purposes, Down syndrome before the age of 21, which they did, then you'd be in this program. But over the years, as each tax time has come, that amount, that number, that age has been pushed up. The same thing happens with how much money you can save and how much you can save each year, and then what the aggregate amount is that you can have for a lifetime. And it does have, and you're able to have your Medicare, Medicaid, SSI, SSDA. You can have all those programs, and it doesn't impact the being able to be in the ABLE Act. So we're looking at that from a conceptual point of view. Is there something that can be done with that could be moved around some more, or it could be built on? That was the first thing. The second option that,
And I'm going to have to ask you to wrap in 1 minute because Rebecca's giving me looks.
Okay. The other option that we talked about too was if they really were to go in and start pulling apart the ACA, could you add a benefit into the ACA that is long-term services and supports? And so it's in everybody's plan, everybody's Blue Cross and Blue, everybody's everything. It's in there. But in order to access it, you have to trigger it. And then what would the trigger be? 2, 3, 4? I mean, you could do it the ADL way or you could do other ways, but could you trigger it? And then what would you give people? Would you give them a hybrid model of some cash, some services, all cash? What could you do with that? And so that's the other piece that we were talking about. If, in fact, it was ever to come to pass that they were successful in trying to pull apart the ACA. So we're kind of trying to come up with things that would strengthen keeping Medicaid what it needs to be, but offering alternatives that aren't available right now to other folks.
Okay. Rebecca, do I have time to take questions from the audience? No? Okay. I'm sorry. I misled everybody. The hammer's coming down on us. Anyway, this was such a great panel. You all were wonderful. Thank you. I hope everybody, felt this was helpful. If there are questions, I think people will stay for a bit, so you can come up and talk to us individually. Thank you all so much.
Thank you.